Hello, fellow specialists. I would like to express my sincere gratitude for performing the simultaneous cardiopulmonary transplant and administering the anesthesia today. Continuing from last time, we will proceed with the second session on simultaneous cardiopulmonary transplant surgery and anesthesia today. We are looking at some of the absolute most complex, high-stakes physiology in modern medicine, so let's dive straight in.
Here is our agenda for this session. First, immunity and the Combi-Effect. Second, postoperative pulmonary complications. Third, neurological, renal, and systemic risks. Fourth, anesthesia and ICU management. And finally, innovations, case studies, and future directions.
Right then, Section 1, Immunity and the Combi-Effect. This is a truly fascinating phenomenon that completely upends our standard transplant intuition regarding the combined heart-lung block.
Before we examine the outcomes, we really must establish our baseline immunosuppression strategy. Our maintenance therapy relies on a rigid 3-drug regimen: a calcineurin inhibitor, preferentially tacrolimus, a cell cycle inhibitor like mycophenolate mofetil, and of course, a corticosteroid. Now, interestingly, in simultaneous heart-lung transplants, we adhered to the lung transplant protocol, not the heart protocol. You might wonder why. Well, it's because the lung allograft carries a significantly higher intrinsic risk of chronic allograft dysfunction. Furthermore, the cardiac allograft in this combined setting behaves remarkably well. In fact, an incredible 62% of endomyocardial biopsies shows zero signs of rejection. Because of this, routine surveillance biopsies of the heart are almost entirely bypassed. We rely instead on annual dobutamine stress echocardiography. For the lung, however, surveillance remains incredibly strict. We're talking bronchoscopy with transbronchial biopsy at 1, 3, 6, and 12 months, triggering immediate further investigation if the FEV1 drops by just 10% from baseline.
And this brings us to what we call the Combi-Effect. Looking at this UNOS registry data, we see a rather striking immunoprotective benefit. The simultaneous presence of both organs actually reduces the rate of chronic rejection. For the lungs, 5-year bronchiolitis obliterans syndrome-free survival is 57% in combined transplants versus 50% in isolated lungs. But I'd like to draw your attention to the heart data, because it is absolutely staggering. The 1-year incidence of coronary allograft vasculopathy drops from 7.8% in isolated hearts straight down to 2.9%. And to put that into perspective for the long term, by 5 years, isolated hearts face a 29.3% incidence of CAV, whilst combined heart-lung grafts sit at just 6.8%. We are looking at a massive, highly significant statistical drop in chronic rejection.
So how on earth does this happen? Well, the leading hypothesis centers on BALT, bronchus-associated lymphoid tissue. It's thought that the host's immune response becomes highly localized in the massive antigenic surface area of the lung's BALT, effectively acting as an immunological decoy that shields the cardiac allograft. Additionally, transplanting en bloc preserves critical lymphatic drainage from the pericardium directly to the mediastinum. We also believe preserved bronchial vascularization plays a vital role in protecting airways from the ischemia that typically drives BOS. And brilliantly, we see this exact protective halo effect in other multi-organ procedures, like combined heart-liver or heart-kidney transplants.
Moving on to Section 2, post-op pulmonary complications. Whilst the long-term immunology is highly favorable, the immediate post-operative period is a profound clinical gauntlet for us all.
Before a patient can enjoy that long-term immunoprotection, they simply must survive the first 72 hours. Primary graft dysfunction, or PGD, is undoubtedly our greatest enemy here. It occurs in up to 30% of isolated lung cases and carries a brutal 40% mortality rate. The deck is heavily stacked against these patients. Preoperative pulmonary fibrosis, pulmonary hypertension, older donor age, the intense physiological storm of brain death, fluid overload, and graft undersizing all play a role. To truly grasp the stakes of our early pulmonary management, we'll look at a 2026 retrospective analysis by Kwon and colleagues, which details the devastating impact of unplanned reintubation.
Kwon's data on this table lays bare the catastrophic penalty of early extubation failure. By propensity matching 146 successfully extubated patients against 146 who required reintubation, the severe differences become perfectly clear. Reintubation more than doubles the 30-day mortality, jumping from 3.4% to 8.2%. The 90-day mortality hits 11.6%, and systemic morbidity absolutely skyrockets. Dialysis needs nearly double, stroke risk jumps to 5.5%, and the hospital length of stay effectively doubles from roughly 37 days to an agonizing 73 days. It's worth noting that independent risk factors driving this failure include pre-transplant intra-aortic balloon pumps and prolonged initial mechanical ventilation, which emphasizes precisely how vital optimal extubation timing truly is.
Now, this illustrates a vital clinical nuance that we must discuss. If a patient fails extubation, their early mortality risk is, as we just saw, exceptionally high. However, if our intensive care teams can drag that patient through that early physiological storm, their long-term survival at 1, 3, and 5 years is remarkably preserved. In fact, it's statistically similar to those who never needed reintubation. Early extubation failure is a crisis, for sure, but it is not a futile condition. Aggressive, meticulous critical care absolutely rescues these grafts for the long term. Section 3. Neurologic, renal, and systemic risks. Beyond the lungs, we have to remember the brain and kidneys act as highly vulnerable bystanders in this process.
Let's start with the brain, 7.8%. According to a 2023 study by Akbar and colleagues, this is the alarming stroke incidence rate in combined heart-lung patients who were bridged to transplant using mechanical circulatory support. The overall stroke rate for the combined cohort is 4.0%, which is already notably higher than isolated hearts or lungs. But once MCS enters the equation, that neurological risk nearly doubles.
Delving a bit deeper into Akbar's data, we find specific independent risk factors. Being on ECMO at transplant carries an adjusted odds ratio of 2.63 for stroke. A pre-transplantable implantable defibrillator carries an odds ratio of 2.86. Worryingly, the overall stroke incidence has steadily climbed over the decades, from 2.0% up to 4.5%, and this corresponds directly with the 2018 organ allocation changes that triggered a massive increase in temporary mechanical circulatory support, and the penalty is severe. Post-stroke 1-year survival plummets drastically from 77.1% down to just 45.7%.
Shifting our focus to the kidneys, a 2025 analysis by Hardy looked specifically at PAH or CTPH patients. The renal trajectory here is literally a double-edged sword. In the 1 to 2 years post-transplant, almost all patients experience a significant decline in eGFR. This is primarily driven by unavoidable calcineurin inhibitor nephrotoxicity, alongside ischemic acute kidney injury. However, and this is a rather beautiful physiological rescue, patients entering surgery with severe preoperative renal impairment often sees significant eGFR improvement by 1 month post-op. Simply placing a healthy heart and lung block instantly resolves their pre-existing cardiorenal syndrome.
We must also acknowledge the long-term systemic threats, infection and malignancy. Because the lung allograft is continuously exposed to the environment via the trachea, these patients face the highest infection risk of any solid organ transplant. Bacterial infections lead the charge, followed by viral and then fungal. Make no mistake, infections are the single most important trigger for chronic allograft dysfunction. Furthermore, robust immunosuppression heavily elevates the risk of post-transplant lymphoproliferative disorder. We see a PTLD incidence of 7.6% here, compared to 5.4% in isolated hearts and just 3.1% in isolated lungs, making vigilant oncological surveillance an absolute necessity.
Section 4. Anesthesia and ICU management. With all these risks in mind, how exactly do our anesthesiologists and intensivists manage this precarious balance? Let's take a look.
Our ICU strategy must be hyper-proactive. To prevent primary graft dysfunction, we employ strict lung protective ventilation, low tidal volumes, precise PEEP titration, and a rigorous fluid balance. The ultimate goal is early extubation, targeting a median of just 2 days. Right heart failure is a constant threat. We must anticipate, manage aggressively with inhaled nitric oxide, prostacyclin analogs, and titrated inotropes like milrinone. For pain, we utilize thoracic epidurals or paravertebral blocks to facilitate early, deep breathing. Renal function is guarded closely by tracking calcineurin inhibitor levels and initiating early renal replacement therapy when needed. Through it all, ECMO has evolved from a rescue device into a full-spectrum perioperative platform for right ventricular offloading, controlled reperfusion, and proactive early recovery.
Now, managing this physiology is quite humbling, really. As this quote perfectly captures, our standard imaging tools, like TAPSE or fractional area change, often fall entirely short when trying to capture the dynamic, complex physiology of a right ventricle tethered to a veno-arterial ECMO circuit. The loading conditions are completely artificial.
We are forced to rely heavily on invasive hemodynamic markers like right atrial pressure, seamlessly blending hard data with deep clinical intuition to decide exactly when the right heart is ready to fly on its own.
Section 5. Innovations, Case Studies, and Future Directions. How are surgical and technological advancements shaping the future of this incredibly complex field?
A major paradigm shift is the expansion of the donor pool, specifically utilizing donation after circulatory death, or DCD organs, alongside our traditional donation after brain death. Looking briefly at these national trends, the utilization of DCD organs in combined transplants is inching forward, which is fantastic, but it's fundamentally pushing the boundaries of ischemic tolerance and bringing preservation technology sharply into focus.
To successfully utilize marginal or DCD organs, we are rapidly moving past traditional cold static storage. Though I should mention, we have seen some brilliant success pushing cold ischemic times up to 589 minutes. But the true frontier is normothermic ex vivo machine perfusion. Using systems like the organ care system, the protocol is highly technical. The pulmonary artery is flushed, the intact block is excised, placed securely in the chamber, and perfused with warm blood at 34 degrees Celsius whilst being ventilated. This allows active functional assessment of a DCD heart-lung block completely outside the body.
However, this technology introduces what we call the machine perfusion paradox. Its practical utility is undeniable. It rescues discarded organs, thereby dramatically expanding our donor pool. But circulating blood through plastic tubing for hours outside the body naturally causes an accumulation of pro-inflammatory mediators. When that heavily primed, inflamed block is implanted, that massive cytokine load directly correlates with a higher risk of severe primary graft dysfunction, prolonged ventilation, and the exact reintubation crisis we analyzed earlier. So whilst we gain organs, we increase the risk of early post-op complications. It is a profound clinical trade-off.
To see how these protocols expand globally, we can highlight a landmark single-center case report out of the Republic of Korea. This report detailed the clinical characteristics and successful surgical outcomes of a simultaneous cardiopulmonary transplant performed locally. The team meticulously applied international recipient selection criteria, successfully executed the complex in-block surgical method, and navigated a postoperative course that perfectly managed the exact complications we've discussed today. This vividly proves the feasibility of establishing these resource-heavy programs in new regions, ultimately democratizing access to this life-saving therapy across the globe.
Yet, even with absolute surgical perfection, we are still fighting systemic allocation glitches. The ISHLT consensus lists pulmonary hypertension as the primary indication for combined transplant. However, in systems like the US, there remains a persistent lack of an integrated allocation system specifically designed for combined blocks. This creates massive waitlist friction and strands desperately ill patients. We urgently need policy updates, perhaps looking toward the Eurotransplant model as a guide. Furthermore, looking to the future, we must move beyond simply measuring trough levels in the blood and shift toward functional immunosuppression monitoring. This will allow us to perfectly tailor drugs on an individual basis to avoid both rejection and PTLD.
I want to leave you all with this provocative thought. We know machine perfusion is the vital future of expanding our donor pool, but we also know it delivers a massive inflammatory hit to the patient. So, how must we radically refine our perioperative ICU strategies, our ventilation protocols, our ECMO use, our cytokine filtration techniques to neutralize that inflammatory load and absolutely prevent the catastrophe of early extubation failure? Answering that question is the next great frontier in cardiopulmonary transplantation. Thank you all for your exceptional focus today. Let's keep pushing the boundaries of what is possible for our patients.